Hello there. Welcome to another session of Digital Slide Review Pathology. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. Our program is a service of the Digital Pathology Association and Path Presenter, which unite to offer this Digital Anatomic Pathology Academy. And that allows you to review the digital slides that I'll be using in my presentation today, the link which will be in the comments below. So I'd like to talk with you a little bit today about not a specific case, but about one of the challenges that arises in pathology when we have to deal with cases that have been treated or partially treated. So I've titled this the treatment effects or interpreting treated samples in GYN pathology. When we think about treatment in GYN neoplasias, there are several settings where this may be a pertinent issue. One, of course, is a very common one, that of the neoadjuvant setting, where the patient may receive a partial or even a complete course of preoperative treatment and then undergo a cytoreductive surgical procedure to remove gross disease and get them back to a near normal baseline in terms of tumor burden. The second setting, of course, is the totally adjuvant setting where they may, or primary setting where they may have a full course of treatment with curative intent, either by radiation or maybe chemotherapy or whatever. And then for some reason, residual or recurrent lesions come to sampling. And then there's another scenario where in the course of treatment, assessments are performed to determine the degree of response to treatment and whether or not further management decisions need to be made. So those are kind of the three settings that I think are most frequently encountered, and by far and away the most frequent are the first and the third one. When you think about neoadjuvant treatment, of course, that usually consists of some combination. Depending on the site, cervix may get both radiation and chemo or just radiation, whereas ovarian serous carcinoma is almost exclusively chemotherapy. In terms of the histologic changes and other things that we see with these agents, with chemotherapy, there's generally a disruption of both the neoplastic and normocellular proliferation. So that itself can result in a number of changes, both within the target organ system as well as in other organ systems. There may be tumor necrosis with a secondary inflammatory response that comes along, and that may lead to a very florid giant cell reaction or histiocytic response, scarring, fibrosis, and shrinkage of those neoplastic elements. With radiation, the changes that we see are definitely very much time course and dose dependent. Ideally, you see tumor necrosis and degenerative changes in the tumor nuclei, but you also can see, depending again on the time frame and dose, endothelial damage, some degree of stromal nuclear smudging, maybe some epithelial nuclear megaly. You may see mucosal ulceration and atrophy, and of course, the disruption of hormonal function, especially if the ovaries are included in the field of radiation. With that regard, let's take a look here at this patient who had an endometrial carcinoma that for varying reasons was not immediately amenable to surgical treatment. And so she was given a very intense dose of radiation. Now, what we can see here at low magnification is that we have a very hyalinized pink endometrium, myometrium down here with a few residual glands we can see here, and an ulcerated surface. So as we look at this surface, you can see that this is ulcer. There's no epithelial lining here. There's blood, there's fibrin, and then there's this loose myxoid tissue. As you look at some of this reactive fibroblastic tissue, you get a sense for some degree of nuclear smudging. See how the nuclear features of these stromal cells is kind of ill-defined. And some of the endothelial cells that we see here are definitely a little bit on the plump side and maybe a little bit kind of atypical looking and so forth. And probably leaky because we see areas of interstitial hemorrhage. But this type of pattern, this type of fibrosis would be entirely consistent with a radiation endometritis, no residual glandular tissue in there. And so likely this was entirely a tumor that responded in this way. If we look down here in the more normal endometrial basalis, we can see some of the similar sorts of changes. You can see there's a degree of nuclear smudging here. They're indistinct. It's not just the focus in the scanning. You see some vacuolar changes, which may also be associated with that. And you see variable amounts of inflammatory cells, a few perhaps lymphocytes around the cells, and some even probably within the epithelial compartments, as you see in several of these areas here. But no residual neoplasia identified. We look at this fairly carefully and section it thoroughly, of course, to identify anything that looks like it might be neoplasia. This raised some concern on the part of the resident because of the small size and close spacing. But I think there probably is stroma around these. So these are probably just adenomyosis type glands that are slightly altered by the radiation changes. And we can see other areas of adenomyosis changes down here as well in this lesion. Now, it may be that here we can see a difference between those other glands. And so here, I think what we're seeing actually here you can see more pronounced nuclear enlargement, larger cells overall. And so this is treatment effect on the intraepithelial component of this endometrial carcinoma. So here are some very plump, large cells with clearly some degenerative type changes that make them look different and distinct from those other endometrial basalis glands. And there's some surrounding inflammation. So this would qualify as a small area of residual tumor, treated tumor here, and possibly still in situ in the sense of it being present in the adenomyosis that is evident here. So that's one pattern of some of the changes that you can see with, in this case, neoadjuvant radiation therapy. Let's talk a little bit more about neoadjuvant setting in the case of high-grade serous ovarian carcinoma. Most typically, we see this following 3 cycles of chemotherapy, although it can follow a full course of 6 cycles. And our response should be scored according to the chemotherapy response score system. And that has 3 grades. Grade 1 is no response, no definite evidence of response. You just still see tumor. Now, it may have shrunk, maybe smaller clinically, radiographically, but pathologically, we don't see evidence of definite tumor regression in the form of inflammatory response, necrotic cells, et cetera, et cetera. A moderate response is kind of a subjective area. There's some response, but it's not marked. And so really anything between no response and essentially no or very minimal remaining tumor is going to fit into this grade 2 score category. Now, one of the pitfalls is, of course, is that histiocytes may mask the presence of residual cancer, especially if they're inclined to form giant cells. Those can be quite deceptive and look very similar to serous carcinoma. The other thing to be mindful of is that these seemingly unaffected areas may actually indicate that there are resistant subclones that are developing. And the other factor to keep in mind, especially if you're going to score something as a grade 1, is to say, did we really get the diagnosis correct? Was this clear cell carcinoma? Was it metastatic carcinoma from some other site? Are we looking at an endometrioid tumor, or are we looking at some other type of neoplasm that is less responsive to our carbotaxol type of chemotherapy that may be our standard in our particular setting. So I'll give you an example here of a pattern score 3. This is omental tissue from a patient who'd had 3 cycles of chemotherapy. And as you can see, we have areas of fibrosis, some fibrin, and then we have all this sort of pale pink tissue here in between. We'll go down and take a look at this. I think you can appreciate here that the pink tissue is very fibrotic. There's a little bit of mesothelial surface reaction, but this is all just very nicely scarred down tissue. And then deep to it, we have this very florid histiocytic response, plus or minus maybe some cholesterol clefts, a few giant cells and so forth, with admixed lymphocytes. So this is quite clearly a response in this area. But then we want to be sure that we are not missing a few things. So looking at things that look different, these dark cells, and scanning over the slide a little bit further will allow us to look at some of the other kinds of areas where, maybe the cellularity gets a little bit higher, more lymphocytes or something, and that doesn't look particularly concerning. This does require a degree of care and close evaluation. Did I make you dizzy there? Here's a little bit of fat necrosis here. This is not a tumor nest or tumor vacuole. But here, someone nicely placed these green dots here. And indeed, here you can see something that looks just a little bit different. Now, you might, at low magnification, say, oh, those are just giant cells. And indeed, they are. These are very large cells, and they could be multinucleate. But notice how different these nuclei look from the histiocyte nuclei. These are many times the size of these fibroblastic or histiocyte nuclei. In fact, even the nucleoli are almost the same size as some of those cells. Now, if you have doubt, you could do some marker stains potentially to verify that these were keratin positive cells. They may retain many of their inherent markers of neoplasia, but sometimes after chemotherapy, you can lose markers or they become paler, or there can be some other changes, and we'll just touch on those briefly later on. But this indeed was an area of residual tumor. And notice just the reactive changes that we've got. So you've got this tendency towards multinucleation. You've got the prominence of the nucleoli, macronucleoli. These are all features that are related to the chemotherapy. They're part of a degenerative necrosing process that indicates a chemotherapy response, but it is as yet incomplete. Now, if we had waited another 3 weeks or something, would this have been more evident and diminished? We don't know that, but we do recognize that this changes the stage, especially since this was the only focus in the omentum. That makes it a T3. Yeah. And so it's not just a T1 disease, even though it's going to be a Y prefix for post-therapy. So the other circumstance, which we see with some regularity, is the hormonal treatment of endometrial intraepithelial neoplasia or low-grade endometrial adenocarcinomas. And this is typically in patients who want to preserve fertility, or in patients who are poor operative risks in terms of obesity or cardiac status or something of that sort. And so typically we're using progestational agents, maybe a Miranda IUD or some other sort of device to deliver progestational impact. And it's to be expected that that will produce a decidualization of the endometrial stroma. Along with that, the hormonal effect will be to shrink down and make very atrophic looking, much smaller than normal glandular elements. Now, tissues that may not respond to that would include some polyps, The endometrial basalis, those would not normally respond, and so those may be found in follow-up specimens. But any degree of architectural atypia should be looked at very carefully, because while it may be reduced with these treatments, it may not be totally eliminated. And then, of course, cytologic atypia also can be diminished by this hormone treatment. And so the architectural changes may be the primary feature you have on which to base your diagnosis of residual EIN or residual carcinoma. So let's look at a couple of examples of this situation. So here's a patient with a history of EIN and hormone therapy, and now a follow-up curettage. And these usually come in the 3, 6, 9, whatever, 12-month periods following the initial diagnosis, maybe a little bit more frequent in the initial diagnosis, in the initial follow-up. And as we look at this, we can see that, let's look first here at what some of the more normal response be. Let's take this fragment right here and say, okay, this looks to me very much like a fairly normal area of decidualized stroma and fairly small atrophic glandular tissues. Now we'll contrast that to what we might see here, for example. Well, that's mucus. So let's look here. Again, that looks fairly good. These are small shrunken glands. And here you see how very shrunken these glands can become. But notice that these glands are still a little bit close together. So we have this very pronounced decidualization, but we've got these glands that are a little bit more tightly clustered and prominent than we might normally expect. So that's a little bit atypical. We'll come down back to another fragment here. And let's look at these two fragments here. So here, we see not atypia, but we do see architectural prominence of these glandular tissues. So this indicates that there's some degree of residual architectural change. Now this may be a polyp. We have some vessels here. And so this may be just an area of simple hyperplasia, because there's certainly no cytologic or structural abnormality to these glands here. Coming over here, however, I think you can then begin to appreciate that in this situation, here we have glands which do not show much in the way of stromal decidual change. The cells are still pretty tall and columnar, not highly atypical, but they look different than those other atrophic glands that we looked at. And the spacing of these glands is much more closely spaced than we would expect. So even in this situation, I think we could get pretty much to the diagnostic criteria of endometrial intraepithelial neoplasia, because our gland to stroma ratio is shifted. And these glands have much taller, bigger cells than these small atrophic normal glands amidst the decidualized stroma. So on those two criteria, with the appropriate size designation, you could still call this an area of EIN in this sample. So there's one nice patient example, and you can come back and look at it and compare these on your own. Let's take a look at another one. Again, this is a patient who had complex hyperplasia or atypical endometrial hyperplasia, and she's been treated to some degree. Now here we see still some persistent architectural abnormality, both here in the low power, a little bit increase of gland to stroma ratio, and we see these very nice prominent squamous morules or squamous metaplasia within these glands. And in addition, the glands are retaining some of their enlargement to their prominence and slightly rounding up of some of the nuclei. So while we don't have closely spaced back to back, we have other features that suggest architectural abnormalities. Notice we have some altered configurations of some of these glands, some budding and branching. So this is compatible with treated endometrial atypical hyperplasia, EIN, with squamous metaplasia, and would be indicative that treatment needs to continue, and there are no evidences of higher grade or frank neoplastic or invasive disease. And you can see the scattered areas that are still involved, and then the areas where the hormone therapy has been taken root and induced a bit of more decidualization. Not as much as you might wonder here. In areas like this looks almost more like a normal proliferative endometrium, which might raise consideration or question about whether or not the patient has been compliant, whether or not the hormone delivery has been effective as well. So only minimally decidualized, but areas of some residual complex glandular structures with squamous metaplasia and the anomalies that we expect in terms of cytologic change as well as the architectural change. So one last example here. And this is a case where I think we see very nicely developed over here the decidual change. And this is kind of the more classical type of decidualization where the stroma is very pale, very very kind of pale pink with these small nuclei. And here you see these very, very atrophic glands that are characteristic of the exogenous hormone effect. So clearly this patient is getting a therapeutic dose. And so the things that don't look like that should stand out. So things like this, we should examine carefully. Things like this that's been dotted. Here's another fragment over here that's been dotted. Those look different than the other tissues like this, which have a more normal pattern. So we'll come down here and take a look at this. And you'll see here that this is not, it's not highly worrisome architecturally or cytologically. It's just different. These are not atrophic glands. There's still a fair amount of cytoplasm. They're a little bit more closely spaced, a little bit of atypia here. And you've got this mucinous secretion here. You can see a little bit of area stella reaction. So this type of an area, again, you may have some polyp features here. Look at this other area as well. This was one that I thought was the most worrisome. And here you see a little bit more of the sort of sloughed cells. And that's the other feature that sometimes you can see here in these treated cases is that some of the hyperplastic epithelium will fragment off more easily and have more atypia. This is obviously sloughed. We don't have the architectural features there, but it does support the concept that there may be a little bit of residual hyperplasia still in this sample. And of course, you want to examine all your levels, all of your tissue. Ideally, you get it on the slide rather than under the edge of the cover slip as we did there. And that will allow you to make a more reliable determination. So you may be thinking, well, this is kind of a subtle change that you're describing here in these cases. And that's exactly the point I am trying to make, is that in these treated endometria, the changes of residual hyperplasia or carcinoma can be quite subtle. They can be quite focal. And so you need to have a high index of suspicion. You need that history, and you need to examine the multiple levels and look at things more carefully. Now, this fragment, for example, I don't think we could make the diagnosis of atypical hyperplasia, even though it looks different. This may be more like lower uterine segment, where we don't have much of the endometrial stroma. So just a sign of, think about the other thing that can happen here is as patients get treated, that there is a process of so-called clonal selection that can occur. And that can sometimes lead to divergent differentiation or a de-differentiation, if you will. And that is potentially going to expose more aggressive clones. And this can therefore also mean that sometimes your recurrent or residual tumor can look quite different from that initial tumor. So for example, we had a serous carcinoma patient who had a residual nodule in her omentum, finally went back to resect that, and it was not conventional clear cell, or excuse me, conventional serous carcinoma. It actually showed a carcinosarcomatous morphology. Well, that can happen in other sites as well, the endometrium particularly. This is a patient who had an endometrial carcinoma treated with surgery and probably brachytherapy, but still developed a vaginal lesion a couple of years later, which of course is why they do follow up in biopsies. But as we look at this tissue, it looks very different. This does not have a gland-forming basis. This has a lot of loose myxoid spindle-shaped tissue. It has some islands of squamous differentiation. It has some kind of nondescript pink cells here, maybe with a little pearl there. A little bit sarcomatoid appearance, maybe poorly differentiated glandular tissue, another keratin pearl down here, some hyalinized collagen in areas here, and then this loose interstitial pattern of stromal cells, which have some atypia, have mitoses, so this we interpreted as being an area of recurrence with divergent differentiation following the therapy. Endometrial carcinoma with squamous metaplasia and a sarcomatoid transformation of the tumor, giving this nice stromal pattern, streaming cells, variable degrees of atypia associated here. Now, could this just be radiation change with kind of the gynecologic equivalent of sialometaplasia? I don't think so. I think the atypia here is too great, both in the stroma. Here you see a fair degree of atypia. You see some atypical single cells. We didn't see actually identifiable strap cells or things like that, but this is not the clustered pattern of pre-existing glands with a sialometaplastic type of change. This is recurrent carcinoma with so-called divergent or carcinosarcomatoid differentiation in this patient. Well, that kind of brings us to the end of this presentation. Oh, actually, no, I guess I have one more case here. And this is to illustrate one of the challenges in this situation. So this is a younger patient, and she had a prior history of a small cell carcinoma of the ovary of hypercalcemic type. And after initial treatment, she had a recurrence. Now, it doesn't appear there's too much of a response here. There's a little bit of necrosis. So maybe this would be a score 1 or 2 in terms of chemotherapy response. But the challenge here was in morphology. This is a very undifferentiated tumor, and it's not kind of the typical small blue cell type of lesion, but it certainly would fit with small cell carcinoma of hypercalcemic type, which can actually have fairly good size cells. So that's just another example of some of the limited response that you may get following treatment with a residual. Now, in this situation, this did not always stain exactly like her initial biopsy had. And we ended up attributing that to the chemotherapy effect. But I think that's an important point to remember, is that once you've begun to administer chemotherapy, that can alter the immunohistochemical backdrop in which you're operating. So we'll close with a couple of caveats here. Grading tumors following treatment is generally not recommended. It's not reliable, particularly if you're basing that on nuclear features or on percent necrosis, as in the case of some sarcomatous lesions. Immunohistochemistry may have features altered by treatment as well, and this clonal selection process. There can be circumstances where the histiocytes or other cells in the neighborhood can take up some of the markers that were present on the tumor that is now necrotic and so forth. Or you have certain circumstances where various antigens can be lost or altered and be less reactive. And you may also get new antigens, or so-called neoantigens, induced that either mask, block, or are completely different from those in the primary tumor in some circumstances. So keep those in mind if you're tempted to use immunohistochemistry to resolve a question about whether this is recurrent tumor or a new primary or that sort of issue. Well, that brings us to the end of our program for today. I appreciate you joining me for this. And we welcome your comments, particularly other caveats or pitfalls you may have encountered in dealing with treatment effects in either the GYN tract or in other locations in the body. There's a lot for us to learn and share with one another. And I always say that, pathology is very much a team sport. So I'm glad you're on my team, and I hope that I've been an effective help for your team. And so until next time, thanks so much for joining me.